Um, Sorry, I'm the last talk before keeping you from lunch, so I'll try and make it brief. But just to build on the last stimulating discussion about APPs, I can speak for Dr. Gruber and I. We cannot absolutely not function in clinic without our genetic counselors, our nurse practitioners, RPAs. They're absolutely vital to the way we practice. And I think we've been lucky at City of Hope Duarte to have one of the leading programs in teaching physicians, nurse practitioners, PAs that are very interested in the field of cancer genetics. And actually, maybe it's a good idea that we invite Kathy Blazer, who's been leading that program for over 2 decades now, in training advanced practice providers in the practice of cancer genetics. We have about 2,100 alumni who do that in the community, but come back to City of Hope to, with their tougher cases. And I think it serves as a model of how we can increase subspecialty teaching and training. And we also invite training fellows to also take part in that so that they get that broad overview of cancer genetics. So that was a great talk. And in fact, it's hard to follow that discussion with this. These are my disclosures, and here's my CLC and implicit bias slide, which I'll be talking about near the end of the discussion. I don't have to belabor this slide because, we have been very lucky to have the world's experts here in this room talk to us about liquid biopsy and multi-cancer early detection. I mean, Dr. Kasi, Dr. Faki, leaders in liquid biopsy, Dr. Tomasetti, Dr. Gruber, Dr. Samatter, Dr. Iannuzzi, they have really framed my discussion already for me. And the discussion of my talk is unresolved issues in MCED testing for the high risk and health disparities angle. But really, in general, there's unresolved issues with MCED testing in general. And I think those will probably inform what we do for the high risk as well as try to address health disparities. But the hope is that liquid biopsies and MCED testings will really fill the gap. The USPSTF really only recommends screening for 5 existing cancers: breast, colon, lung, cervical, and prostate. But about 50% of the new cancers diagnosed within this year are going to be for cancers for which we do not have any screening recommendations or a screening test for. And so MCEDs are really, the hope is that they can position themselves as adjuncts to evidence-based cancer screening to screen for these other cancers. I took this slide from the NCI Division of Cancer Prevention as they were talking about their upcoming randomized control trial. And as you can see, this field is absolutely a tsunami that is about to attack the community medical practice of how many commercial and industry leading companies have been trying to get into this space. And so how do we sift through all of these new technologies to find out, which are the ones that we should actually be practicing and using within our clinics? So what do we know? What do we know now in general for MCED tests? Well, this is taken from a systematic review of the current state of blood-based MCED testing. And in the last few years, 6 MCEDs have been evaluated, but there's greater than 15 that are currently in development. Of that, of the completed studies that we have, there are 13 cohort studies and 17 case control studies. And then in terms of the ongoing studies, there's only 1 randomized control study, which is coming out of the NHS Gallery test, and then 5 cohort or case controlled study. And among these different studies, there's 40 to 50 cancers that are being screened. And all these different MCEDs are testing different combinations of ctDNA, proteins, exosomes, and methylation sequencing. And in general, what I can say is that the level of data that we have is low quality. We don't have any finished randomized control trials. We really have a limited follow-up of duration and variable gold standards that are being compared to these tests. Limited data in asymptomatic screening populations over the age of 50, And the outcomes have been also limited. We don't have good mortality data. We don't have good harms data. We ourselves have kind of entered into this space. I'm leading this Adela MSED testing validation study where Adela's been using a commercial platform that helps to enrich methylated DNA for sequencing, with the idea that it can harness better quality substrate for their analysis and assay. And since October 2024, we have enrolled 5,300 patients across different sites, including Mayo. But at City of Hope Duarte, we've just hit over 1,400 patients enrolled. But with all of this, with all these different cohorts being enrolled, even the NCI felt the need that before commercial entities could get directly to the patients, they needed to conduct a randomized control trial in order to figure out which MSED test should be used in the market. And so they launched what they're calling the Vanguard randomized control trial. And they had sent out an RFA to different centers to see if they wanted to be considered an access hub, where there'd be an initial recruitment of 24,000 patients to 2 MSED studies, with the idea of, based on that preliminary analysis, there might be a larger 200,000 patient randomized controlled trial afterwards. They recently chose the 2 MSED tests that will be part of this Vanguard study. They're using the Guardant Health Shield platform as well as the ClearNote Health Advantech. And these tests will be looking at 10 cancer types: lung, breast, colon, prostate, bladder, ovarian, pancreatic, esophageal, liver, and gastric. And they'll be looking at outcomes of feasibility, adherence, cancer incidence, and stage. And as you can see from the figure, it's kind of hard to see over to the left. They've already chosen many of the sites that will be enrolling the general population. Within California, they've recruited the Kaiser Permanente sites, but they've also chosen places like Henry Ford, Oklahoma, University of Colorado, to really get at that general population. But with the introduction of MSEDs, and at first we were actually thinking that this also might serve as an example of what happened with just genetic testing in general, with commercial companies going direct to consumers. We're starting to see a changing care delivery paradigm in medicine, where traditionally a patient would see the physician, and then the physician would recommend certain tests and follow-up. But now we're bypassing all that. These companies are going direct to consumer, and these patients are then going to their MSED tests or to their whole body MRI that's being advertised by Kim Kardashian. And we're seeing in the community that there is a decreased tolerance of medical paternalism, a decreased faith in the public health system. So where are we bottom line? Should MSEDs be used in an adjunct for evidence-based cancer screening? We don't have the data yet, not yet at the population level. Could it be considered per patient basis? I think Dr. Samatter could help inform that discussion. But there's still core issues at hand. No MSEDs are FDA approved nor insurance covered. We do not have high quality randomized control data. We're seeing that even within these tests, there's lower sensitivity for early stage disease. And what do we do with the false positives? And as Dr. Iannizi had so elegantly put it in his talk, what are those overall costs that we're going to incur in trying to work up those false positives? Really going after affordability, feasibility, and the ethics of doing that. And then the several main remaining questions, this idea of overdiagnosis and lead time bias. Are we diagnosing cancers earlier, but is it really leading to better mortality, better survival? What is the gold standard for diagnostic resolution after positive screen? And where is there insurance coverage for that? And then how frequently should we administer these MSED tests? And then what is the primary outcome that we should be looking at? Should we be looking at stage shifting from late stage cancer, or should we be looking at the traditional outcomes of mortality? cancer-related versus all-cause. And then transitioning, how does this have a relevance to the hereditary cancer population? So let me summarize what we know about MCEDs and hereditary cancer syndrome. So do MCED tests work within hereditary cancer populations? It's not clear. There's different mechanisms of carcinogenesis within our patient populations who have BRCA1 and 2 versus Lynch syndrome versus Li-Fraumeni syndrome. But there have been some initial studies that have looked at these specific populations in feasibility. So there was one study out of Toronto looking at Li-Fraumeni. There was another study looking at the malignant peripheral nerve sheath tumor population who had NF1. But these were small studies. But in Canada, they've already created this CHARM consortium to use a cell-free DNA in hereditary and high-risk malignancies population. And this is a consortium made up of 8 genetic centers across Canada, hopefully 9, with Dr. Ianuzzi's leadership. And what they're going to be looking at is patient acceptability, looking at the benefits versus the harms of undergoing this type of testing. And then provider acceptability versus looking at how providers felt after using this type of testing. Dana-Farber is also engaged in their study called the INFORM study, which is a prospective trial of 1,000 participants, where they'll be enrolling Li-Fraumeni patients over the age of 22, or other patients who are carriers of different mutations over the age of 35, and then patients who have a family history of cancer but no pathogenic variant over the age of 45. And they'll be looking at test characteristics like sensitivity and specificity, as well as patient experience, and they'll be using the Grail Gallery test. But even at City of Hope, we have our own experience looking with a feasibility trial that was led by Stacy Gray and Dan Raz, one of our thoracic oncologists, of patients undergoing MCED testing as well as whole body MRI. So they enrolled 100 patients. 33% had a germline pathogenic variant, with 73 of these patients having at least a high-risk family history. And of the patients that they enrolled into the study, 4 patients were found to have malignancy with the MCED and whole body MRI. One had an early stage lung cancer, prostate cancer, one had a neuroendocrine cancer of the duodenum, and one had an ovarian mass. And then they followed up with these participants with validated questionnaires, and about 98% of the patients were satisfied with the research study. And then, encouragingly, Dr. Gruber will be leading our multi-cancer early detection in those at high genetic risk NCI study. This is a study that has just was announced, and we just got the notice of award. It's a very small study at this point, but we are organizing with different clinics across the nation. At this point, we know that results may not be returned to patients, but the purpose of this is to validate these tests within high-risk individuals. Now, switching gears to health disparities, I think we all know that there's huge health disparities in patients with cancer. Underserved groups often experience late-stage cancer diagnosis due to barriers across and accessing screening and healthcare. We know that patients with low household income have a lower screening prevalence for the known USPSTF recommended screenings. My friend Fola May had conducted a study showing that colorectal cancer screening rates are significantly lower among Hispanic as well as racial ethnic minority groups. And then socioeconomically disadvantaged individuals are also much less likely to obtain lung cancer screening. So just setting the context, and just to make this more real, this is a chart, an illustration showing the 5-year survival of patients for all cancer. And what you can see is that Black males and female cancer patients relative to white patients have worse outcomes in general. And this isn't due, at least in part, to the disparity in early cancer detection rates between Blacks and whites. And so how do we address that in the context of MCEDs? Well, we have to take a really thematic approach to it. looking at specific areas in an organized way. And so we can look at systemic problems, we can look at structural problems, and we can look at personal problems. But when we're thinking about addressing health disparities, especially for MSEDS, we really have to think about the studies that we're conducting and really trying to increase the diversity of research participants within those studies. We also need to be able to build trust with a culturally competent workforce, as well as the community, to engage participants to be a part of these studies. And then structurally, when we're thinking about MSEDS, we really have to think about the affordability of the testing. Dr. Iannuzzi did a really great job at looking how cost of a certain test will really dictate if a patient goes forward with the testing or not. And then we really have to work on the test specificity. If we are leading patients down a diagnostic odyssey, they will not return for their ongoing screening to us. And then lastly, in terms of design and personal barriers, we really have to educate our community on the needs of this type of testing. What are the pitfalls? What are the benefits? What are the harms of it? So really where we're at is we have a lot more questions to ask moving forward. How do MSED tests have the potential to address health disparities, particularly in the underserved communities? What are the specific challenges in implementing these MSED tests across different racial and socioeconomic groups? In regards to our high-risk population, what's the potential impact of these MSED tests on those with an inherited susceptibility to cancer? And then what are the potential advantages using MSED tests in the high-risk population compared to standard screening? So a lot more questions. Hopefully we'll have more answers at the next year's seminar. Thank you.